I don't remember what order it's in, so it could be
Oh
bad.
boy.
It could be bad. Yeah. All right, here we
Uh,
are. Here we are. Melissa's here. Melissa didn't know she was live last time we started recording, so here she is.
oh well.
Amazing, amazing community moderator. Here she is.
Hi,
Okay.
everybody.
All right. All right. She's gone now. Hello,
You're
hello,
like, here
Lisa
you are.
Berry. Happy
Hello,
birthday.
Kat
Lisa. Happy
McDavitt.
birthday. Happy birthday. You're
Thank
now
you.
32, right?
It's 22 actually, but thanks for
Oh
asking.
shit. Sorry. Sometimes I get I'm not good at numbers. So yeah. All right. All right. Lisa, what even happened? Actually, you know what happened? I'll tell you because I made you a deck.
Oh
This is an
no.
actual deck. Are you ready? Okay. So obviously I'm on the first slide because that was the most important part of the week. Okay. So you guys, this week, Leslie and I went to New York City because we are now LPs with Ben Freeberg's Oncology Ventures Fund. And it was so fun.
Amazing.
Save America. We're going to cure cancer. We're going to do all those things. It was so fun. So here we are. This picture I think is great because it looks like Ben has a halo of holy
He
sainthood
does.
behind him.
In real life, he has a halo. Like he has a halo. He's an
Yeah,
angelic creature. Truly.
agree, agree. So we're going to talk more about that later. We're going to do like Leslie and I are going to do some announcements of how cool that is. But that was a cool thing that
Nice.
happened. And then here's okay.
Oh
See how
my
these guys
God.
are moving? This is like, listen, I have upped our technical game so very much.
This is incredible.
So I know this is what you really wanted to talk about. This was you were sending me all kinds of signal messages about this. The
I
Hatco.
was.
What do you
I
think? What do you
was.
think about the Hatco acquiring this lovely health system in Ohio?
So, I mean, first of all, hilarious name. Big ups to the General Catalyst team for creating a ridiculous acronym to describe their own venture, Hatco, to acquire a health system and I guess do experiments on, let's just call it the people of, in this case, Akron, Ohio. Doesn't sound so good when you put it that way, but we'll see how it
Well, yeah, that's like
goes.
bad things happen to people in Ohio, so it is a little sad to think about that.
It's pretty rough. I mean, I think there was lots of interesting analysis about this, including from our friend of the show, Brendan Keeler, who is
Here he
always
is. Here he is.
very confidently wrong sometimes. Sorry, Brendan. Sometimes you're very right, but sometimes you're very confidently wrong. And this was very interesting. There was a real dust up here about what is it going to look like when this big, massive venture capital experiment, again, let's call it experiment, on acquiring and transforming a health system runs up against an Epic shop, whether it's the billions of private money in Epic and the billions of private money in venture. This will be very interesting to see how it goes.
I'm interested. I also love one of the reasons. Well, I do love Brendan Keeler. I have another shout out for him later. And I will say, Brendan, you
Nice.
may think we're making fun of you, but not sure if
We
you know
love
that
you.
my tagline is actually often wrong but never in doubt. So welcome to the club, my friend. Welcome to the club. But here, yeah, I don't know about the Epic thing. I don't know if it's such a big deal, but I also loved this because you sent me Brendan's comments and this. As everybody knows, you send me all my stuff. But our friend Ritesh Patel was also on here, and what did he
That's
say?
right.
Not bold enough, baby. He was like, nope, not good
Keep
enough.
going. Keep going. He was like, do
Oh
more,
man.
work harder. I think this really comes down to the fact that, where are there possibly savings that don't harm patient care? Good luck, everyone. But I do think that the way that we use health information and the massive costs around implementation, purchasing these licenses, getting people to actually use it, actually using information to improve care, that's still a big old green field. And Epic has a huge amount of money and a lot of implementations that have been tied in for many, many years with these massive health systems. Uh-oh,
Yeah.
we lost Kat's
Oh,
video. There
I
you
don't
are.
know where oh, weird. That was,
You're
well,
back.
my kids have little friends over, so we could be having
Uh-oh.
bandwidth issues. Who knows?
No.
But you know what? The point is I'm back. But I will say again, I know some people disagree with me here, but like General Catalyst wants to make a Hatco and then buy a failing health system in Ohio. Like, God bless you. God bless capitalism. Go for it. No problem. All right.
I mean,
What's that?
not sure
Oh,
I agree.
we,
Oh, look
well,
at our
I
other
know, but
favorite
that's okay.
person, Alex
I put
Muggy.
hearts. I put some hearts on her.
Aw,
Yeah. So you take this one, Lisa, because this is,
that's
like close to your
amazing.
heart.
Yeah, so this is a like long saga of trying to get this rule finalized. This is like the successor rule to the CMS interoperability and patient access rule, which I worked on with our friend Tom Novak and with Alex Muggy, who is now the chief health informatics officer at CMS. total badass, absolute star. Just continuing to kind of plug away and get this work done behind the scenes, like trying to truly move CMS forward in interoperability. If you don't know this, CMS regulates and pays for about at least a third, if not more, of health insurance and health coverage in the U.S. And in their role there, they have the ability to also regulate and ask for certain things from certain payers: Medicare Advantage, Medicare managed care organization, Medicaid managed care organizations, rather, CHIP, Children's Health Insurance Plan, and other similar types of CMS regulated payers. And they're just continuing to sort of chip away and get these folks to use FHIR APIs and actually make interoperability and exchange a requirement, which is we have to do over time. And this rule, the prior authorization interoperability rule, also really tries to move prior auth to behind the scenes APIs, make it easy, make it required. And they're actually now further ahead than the rest of the commercial market. So, big ups to Alex. Take a look at the summary. They've continued to do really important work. This rule also is like kind of cursed. So it's amazing they made it across the finish line. This was actually in part finalized in the final days of the Trump administration, then it was overturned and pulled back by the Biden administration. They did it again and made some changes, and here it is finally at the very beginning of 2024. So again, persistence, like this is what it takes. Alex and her team are just continuing to chip away at this and being kind of doing the Cat McDavitt style of, we're just going to get it done. We're going to find things people can agree on regardless of administration and make it happen. So again, big ups to this team.
Get stuff done, worry about how it happens later. I don't know. I feel like Alex also worries about the latter. Like she seems to worry about how things actually happen. So that's like, she's like a unicorn basically. So congratulations, Alex and team. Oh, okay. They're cool. So I put this image on here to make fun of it, Lisa, but nice. I know we're all kind of excited about I thought it was integrated behavioral health, but innovation in behavioral health model that your friends at CMMI came out with. And I tried to read this fact sheet and I was like, what the hell? Like, I don't know who they paid to do this, but hopefully it was not an outside agency because it's real bad.
Yeah.
And you can't read anything. But what do you think about this model? I mean, I was kind of excited.
Yeah, so like it only just launched basically yesterday. It was announced yesterday. It's been being worked on for a long time, as we know. Friend of the show, illegal friend of the show, Tom Novak has been involved in trying to get them to find ways. Illegal friend of the show, trying to find ways to bring in more funding for behavioral health on the health IT and the innovation side. Just as a reminder, if you go back in time and you say, okay, the U.S. spent $1 gazillion on getting providers of different stripes to adopt health IT. Everyone says, it was so much money. It was $36 billion. They forgot like a bunch of segments of the population, including behavioral health and many, many others. And one of the most notable ones, of course, is that behavioral health, health IT, behavioral health, data sharing, sensitive data sharing. This is all totally lagged behind. Huge problems for people's care, huge problems for whole person care, huge problems for the mental and behavioral health crisis that we find ourselves in. And this is just one additional way to try and get at that. They're trying to do things to streamline the way that behavioral health payment happens, make more population-based payments, find ways to actually support the adoption of technology. Really important stuff. But again, just as a reminder for folks, this is a CMI model. It is a time-limited test of a certain new way of delivering and paying for care, and therefore it will not on its own solve all of our behavioral health, payment, and technology crises. But it's a great start. It's been going on for a long time. They've been working this forever. So it's great that it finally made its way across the finish line to be announced at least. So now you can be part of it. So definitely take a look and read about it. Totally doing the government's job today, just like doing the outreach, but
just doing the fact sheet, free. Yeah, and what I like about this is it's like the state-based stuff, right? There aren't necessarily as many of those as some other of the CMMI models. And then I saw this from our friend Dr. Andrei Ostrovsky on the internet, right? He does this thing where he's like, this is why it won't work, but then he does this thing at the end. Love that guy.
This sucks, but that's a great team. Uh-oh, you guys. This might be that I have to run the talk show myself because Kat is not here. Hello. Melissa? Anybody else still there?
I'm still here, so you can.
Amazing. Okay, I'm going to keep going until Kat gets on because this is how we roll. Clearly, her kids are like playing like whatever, some kind of online game or something that's taking up all the bandwidth. So, again, with this model, it really is limited in what it can do. However, like Kat mentioned, the state-based models are really what's happening more these days with the new approach and the strategy refresh from CMMI. So they basically said, okay, we really want to take into account all the feedback that people have given us about why our models have maybe worked or not worked as well, and that is the result. We're having all these models that are focused on working with Medicaid, working with states, et cetera. All right, so that's this one. I don't think we can control the screen, so we might have to do a little stop the show for a second here.
Okay, well, I'm going to how about I go off of the comments that we have going on? There's nothing crazy,
Awesome.
but I'm just going to say, yo, 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 happy Friday back to Ritesh Patel. You know how much I love Patel.
Nice.
And Sarah Abrams, yeah, you know that we are loving the prior authorization. It's also the bane of our existence. So we're super excited about that. And with
Nice.
that, our lovely host, Kat, has been back and has fixed her technical difficulties and
Who controls? Who also unfortunately controls the screen? So when she's
Yeah.
gone, there is no show.
We're fucked, basically. Yeah. So we might fix that. Listen, with our first sponsor, we might buy another seat for Vimeo. I don't know. I don't know what happened
It's
there.
very
I don't
expensive, you
know.
guys. Like, come on, this is
Yeah,
a very
it's
low
like,
budget operation.
listen, it's like $800 a seat.
Dude.
So anyway, okay. The other
All right.
exciting thing that happened, blah blah blah. I'm sure you guys said amazing things. I could hear you, but you could not hear me. It was like one of my nightmares where, yeah, I was really sad.
Totally.
So we got this chief competition officer. I don't know. Seems good. Seems like not bad. You know.
Well, it's a good idea, but it really, again, sort of underlies or underscores our argument that it's probably time for a chief patient officer at HHS. If you can just create a new kind of random chief competition officer, no offense to this lovely lady who obviously is going to have a very, very important job, it's time to create a chief patient officer role. And there is definitely space. There's definitely work to be done. And I think they can work together even because the issues around anti-competitive behavior in health systems are also really, really relevant to patients. And patients also need health systems that work.
Agree. Patients need health systems that work. 100% agree. But I also just love the idea that we have chief competition officers. I don't think it's not a zero sum game here with all the C-suite officers we're adding. All right. Other thing that I found on the internet, Lisa, our friend Jim St. Clair posted this, as a bunch of other people too. Basically, less people are dying of cancer, but more people are being diagnosed with cancer. This seems like not news to me, but I might not have read it all the way. I feel like, yeah, we have more early detection,
yeah.
right? I
don't know yet the confounding fact. Like this in me, like as a person who took, various types of program evaluation courses in public health school, like makes my little like I kind of go like, oh, I don't know, maybe there's some confounding factors here. Like we have way, way, way more detection in terms of way more early testing for people who might not necessarily need to be tested. So I don't know if that's the case here, but I'm a little bit like, it could just be earlier and better detection, which is good. So I don't know for sure, but I do like to see that cancer deaths are declining. However, I would encourage everyone to do the stratification, look at the different race and ethnicity numbers here and where people actually live, because I'm pretty sure that it is declining in a certain group of white, rich people and probably increasing or staying flat in other groups in these divided states of America. Thank you, Kat.
God bless
for
America.
allowing me to say that.
Yeah, I agree. Well, here's the thing. I would like everyone to remember Lisa and I are former PR girls. And so like both of us knew that you could make things say whatever. Like I know there's like statistics and like science and stuff, but like you can make this shit say anything you want. So yeah, so I have to actually read into it. But yeah, overall it is nice to see that, less people are dying. That's great. Okay, Lisa, we're going to talk about the Chevron discretion thing at the end of the show. Because I made this deck for you. And the next slide is a great transition to our first guest, Timmy. I actually can't remember if Alex or Timmy's first. Alex, sorry, you're second. Timmy's first.
She's second.
Look at this guy, Paul Norton. Look at him.
Just getting a job. Paul.
Just getting a job with Blue Path Health. What?
Yeah. Paul, a great colleague who has had many intersecting paths with me over my career. He was at Athena, as many people know, the tough competition to the infamous Practice Fusion. And then also, of course, Paul was at Manifest Medics for some time, and then he was just recently at Oscar. And now he has come back to serve the very lucky people of California through work at Blue Path. And so we're super excited.
Yeah, I will say, Paul, I first met Paul when I was basically crushing it at Collective Medical. Obviously, I remember it that way. But I remember like kind of getting smoked by Paul with some California regulatory
Oh
stuff and being
no.
mad about it. It was like one of those like, it's like whenever the lad from Epic,
Like
I'm like,
game, respect game. Is that what you're trying to say?
high fucking five, dude. Like that's kind of how I felt about Paul. And then I may or may not have tried to hire him at his last job, but it looks like he
Nice.
found a different job. I don't know. I don't know what happened, but
Ouch.
congratulations, Paul. I know. It's so sad. And that's a good transition to Timmy Leslie. Lisa, introduce our guest.
Okay, so Timmy is awesome. She has a long history in the biz, so to speak, Manatt and others. And then she runs and founded BluePath, which is a consulting firm in our space that focuses on California, not exclusive, maybe a lot of California focus. And also, she also founded and is the CEO, I believe, of Connecting for Better Health, which is a new nonprofit convener really focused on advancing the data exchange framework in California. Obviously also deeply involved in Civitas through BluePath and now Connecting for Better Health, and just also my neighbor, which is amazing too. So yeah, there's so many great things about Timmy, including, of course, that she's my neighbor. So hi, Timmy.
Welcome, Timmy. I met you that one time at that party.
We left you muted. I'm sorry. You got to unmute. Tragic.
Oh, hi.
Yay.
Did I hear happy birthday?
Yeah.
That was my birthday. And I got these beautiful flowers here from possibly someone who is in the virtual room today. So there you go.
Oh, well, happy birthday. I'm so glad to have you as a neighbor.
Thank you.
And thank you for the introduction. What do you guys want to talk about?
Oh my gosh. I mean, I think you should tell us why. You should tell us. So we talked briefly in the past about the data exchange framework and how it relates to TEFCA and NOD and what's happening in California. Tell us in your own words, and please forgive the framing, why the data exchange framework is not dumb. Why is it not dumb? Why should we care? Why should anyone care?
Because I want to say too, before you start, we have our great friend Kevin McGavey from Manatt, who often, pretty much every time, corrects us about things we say about the data exchange framework. So we're like here for some facts.
Yeah.
Awesome.
Yeah.
Well, we started Connecting for Better Health, which we're so proud to have as a nonprofit. We just, changed our status at the end of last year, which is a collaboration that we stood up to be able to give a backstop to the governor and the legislative leadership 3 years ago when they decided to go down this kind of interoperability path one more time. We've done it every decade, it seems like, in California, and hopefully this time it works. So maybe that's why we should care about it. But that is, so the data sharing framework is a result of a piece of legislation that was passed 3 years ago, AB 133, and it requires organizations to sign a single data sharing agreement that everybody in the room gets to have all their attorneys make no changes to it, which I think is really important. And in addition to signing that agreement, abide by the rules of the road that the state is rolling out on a regular basis to be able to, give guidance around and clarification around how best to be able to get a message from point A to point B to support a multitude of use cases. So I think we should care about it because it's another lever or another tool in our toolbox where when we encounter, information blocking or just non-collaboration among stakeholders that should be collaborating, there's another reason to be able to point to say that it's a law now, and here's what you are not doing, and where and why. I guess that's why we're here. What happens when folks aren't abiding by it? So, good reason to care about it. Number one, and it's supposed to go live in about 10 days, so good timing here to be here on January 31st, and we can look back and see. I think we heard, get your heads down, get it done. And then now we got to just keep improving it over time. I don't know if I answered your question, but
so why is it not dumb?
I think it's that whole history of 20 years of trying it in this space in California of a population of 40 million and growing, We are geographically diverse.
Bigger than most countries by far.
That's
just
right.
so you
Bigger
all know.
than Canada. Bigger than
Canada.
And geographically diverse. And I think really importantly, when you compare us to other large states like New York, we are not, our health systems are also not geographically diverse. Our public health systems are not geographically diverse. And in fact, our health plans, the way that our coverage in the state is by design, not one coverage plan. We have at least one in every geography to cover Medicaid, and then of course all the other business lines. So we just are a big collective mess. And in order to make sense of it, I think the data sharing framework took another completely different approach that I have not seen any other state. And Lisa, you can let us know if others are trying this, but not contracting with one data utility or one health information organization, not mandating that or ordaining that system to be able to kind of track everyone, all 40 million of us. Instead, it is there's no technology really. It's really about the market going and figuring it out based on a set of rules. And they did just, the state just about a month ago qualify 9 different health information organizations. But again, very importantly, said, go at it, like figure it out. How are you going to become a network of networks? And I think that that is where I think we have the will and the way to do that. And we're going to have to figure out how that all kind of sorts itself out, which again, why we have Connecting for Better Health, because we want this to work. And we are continuing to kind of push the lever or the gas pedal to make sure it works well and quickly.
Well, yeah, this is what we don't talk a ton about my work at Civitas on Health Tech Talk Show, because it is, it's related, but it depends on the context. In this case, right, it's important to understand that you obviously look across the country and many, many states have roughly one nonprofit health information exchange organization. And then you have California, New York, and Texas. And you can forget everything I just said. And there are different structures based on like how those states work and then a bunch of historical factors. So, New York really has probably the most structured option with a coordinating entity in the SHINY and then New York eHealth Collaborative, which is like I don't know, describe it as a quasi-governmental organization. It is
governance.
Yeah. And then you have these, regional health information exchange organizations. They're called qualified entities, and they have the SHINY, which is actually a network that is statewide. And then there are a bunch of other factors and other private parties who are involved in different ways, and every hospital doing their own thing as well. But then you look at Texas, and it's just like totally like we barely talk to each other. We have so many great friends in Texas, and they're working their butts off to make this happen, but it is not coordinated at the state level in the way that you might see in other states. And then you have California, which is like kind of in the middle / trying to find this middle path, this federated model within a state, if you will. And I mean, we also know, and of course, Kat, you know this from your time at Collective, and friend of the show, Sunil Ratan, also knows it from his time at Collective. He describes his job as having drilled a bunch of wells for Collective, which I thought was amazing. I love that. It's a hilarious metaphor. So, California is not just a massive, massive state. It also has delegated so much of this work to counties. And there are a lot of counties, and they are all very, very different, and they have all these different structures. So it's just like doing this at a country level, honestly. Like that is really the California experience.
Yeah, and I think getting back to why I hoping this experiment works and that we shouldn't ignore it, is that it gives the tools and the guidelines available to partners to be able to sit around the table and figure it out. And, the experience that I've had working 20 years ago in this space is not having the way to be able to bring everyone around the table and say, okay, this is our starting point. Now, what are we going to do? How are we going to iterate it? And how are we going to start continuing to make progress? And we couldn't even get the entities around the table. So I think this is one of those huge forcing functions. And interestingly, if you look at those that are signing the data sharing agreement, and it is your typical hospitals and health systems and health plans, but also social services. And I just want to make note of that California is, hopefully we can leapfrog and really figure it out from the start and design the systems around not only patients and providers, which I always say is really important to make it seamless with providers, but also these social services and those organizations that are really taking the weight of whole person care. They're also as part of that design. So that's another reason to really take note of what we're doing and how we're moving through this work.
Definitely.
So in some of the states Lisa mentioned, some of that was driven because, like in the New York model, that like there was no way a state with so many people and such a diverse geography, different settings would be able to have just one HIE. In other states like Texas, right, it was like, God bless America. This is like, let's compete.
We're doing
right?
whatever we want to do.
Yeah.
We're going to compete with each other.
I'm here for all that. But the bummer in this case, when it is something that's kind of acting like a public utility, even in Texas, where I know that that's not what they say, you still like one of those entities going out of business because of a competitive environment.
Big deal. It's
quite
deal.
disruptive.
Yeah.
It's quite disruptive. So in California, I know that the full intent of the QIO model was not necessarily competition, but do you think we'll see something like that where there's many? They'll condense, they'll merge because America, and then you'll have disruption, or do you see them being stabilized? Because I know the funding isn't necessarily there to support the QHIOs.
The state is not funding it, just to be totally clear. We have a big budget deficit. I don't know what we did with all that money, but it is gone. There is a big hole where there was previously a massive budget surplus. So Gavin, any updates? Want to let us know? If Gavin Newsom is watching, he can definitely come on the show and tell us.
Yeah,
I love it.
Call us.
I think there will be some normalized, I guess, some kind of settling out of those of organizations of being able to either organize themselves around a geography or a population of focus. And also, what are they going to do really well and what are they going to compete on? And I always think about health information organizations being really quite a utility, and like Epic, I'll put them there too, like push all that down, and like have the apps be on top that are really customized for that specific provider or for that patient. And I think that these qualified HIOs are going to do a little bit of both. They're going to figure out where and how to get the information where it needs to be. But then also, what is that really slick layer that's going to help make it really meaningful? And where and how do I need that information right now? And how is that displayed to me? And where and how are my partners getting the information that they need? And that's, I think, where we are going to see competition. And I haven't really seen it yet. I think it's the promise of where and all this is going to work itself out.
Well, and also, I mean, what the experience with Connecting for Better Health is just massively interesting to me because, of course, it is sort of the model in which Civitas exists, right? Trying to find a way to bring together a bunch of different stakeholders, right? The nonprofit HIO organizations, the nonprofit QIO organizations, the various technology partners, health tech companies, companies that are providing health data, health information exchange infrastructure. And TIMI is basically doing something very similar on the California level centered around the data exchange framework. And I mean, TIMI, we don't want to get you in trouble here, but it gets a little spicy sometimes, right? I mean, you've got people who don't necessarily agree with each other and you're saying, hey, I need you to come to the table. We are all trying to make exchange happen in California. Any tips, any tales from the spicy nature of bringing together stakeholders who may not always agree?
I love it. I think that's why we have to have a space and a place to have those conversations. And without it, people just go to their corners and, aren't able to really understand where and why they might actually have some agreement. So bring it on. For all of you that join us at Connecting for Better Health, we're there we meet twice a month. We would love to be able to understand your perspective and be able to weave that into our point of view, which is always, grounded in principles that you can review and hopefully they really are meaningful to everyone who comes to our tent. We do want to accelerate data sharing in a safe and private way with all the necessary, boundaries to be able to keep that information safe and get it to where it needs to be. And I think when I step back on this, we all can agree. We all have stories. I can tell my own personal stories of being this huge advocate and still not being able to get the information for my daughter where it needs to be when that provider is caring for her at the right time.
Yep.
And I've been doing this work now for 30 years and went through two two daughters who I interviewed I interviewed the pediatrician thinking, what do you have an EHR? That was one of my questions. And of course, all of the pediatricians in all of Marin County came back and said, no, we don't have an EHR. It's all paper-based. This was 20 years ago. And I think there's just a grounding of we all know we can do better and we need to do better. And we can find that common vocabulary. So bring it on. I love the spiciness.
Well, technically they have an EHR now, but they don't actually do data sharing. So now the question is, do you actually proactively exchange data with other providers? Do your referrals come with a full component of sharing electronic health data? Can I access my data fully, or am I limited? And the answer is going to be, I got to check on that. But the answer is actually no.
Yeah.
But the bright spot is, 15 years ago, it was, do you e-prescribe?
Right.
And the answer was no. Now we at least have e-prescribing.
Now they do that. Yes.
3 years ago, do you have telehealth or virtual health, prior to the pandemic? And now we're there. So there are bright spots. I think we can get there. It's just, yes, we need to get the data flowing.
So big question, national question. So we have TEFCA. We have the data exchange framework in California. Some would say these are duplicative systems. What do you think about that? Not systems, ways of exchange frameworks. Yes.
So the data sharing framework or data exchange framework in California will cooperate with the national framework, but I think we're going even further. So I think that it allows us to be able to push on those use cases that the national framework does not support today. So example of that is, how do you get an ADT alert and push it to those right organizations that need it when somebody is either admitted or discharged in a hospital? How does that happen with the TEFCA framework? Right now, it's not supported. Where and how do we support social service data? So that's where I think where we in California can actually have a lot of impact really quickly if we do it right.
You want to show them up?
We have to work together.
I'm into it.
I mean, arguably things start in the states and they move to the federal government. This is a little bit different, and we'll see how this plays out. I would certainly love California to be lapping the federal government and the national approach. So let's see if we can do it.
Well, I also think we need to be a little bit more in concert with each other. And that's one thing with Connecting for Better Health this year is how, in our work with Civitas, Lisa, is how do we kind of bring that national voice into the design of the work that we're doing here. We need all the help we can get, and we can't be a silo in California either. So where and how we can get that for those listeners, that's another big, at least area that I want to really work on this year is how do we partner better?
So Timmy, before we leave you, or you leave us, whoever pushes the button, I guess it's me. We have a comment from loyal follower Ritesh Patel, who says, it's a rumor. I hear that the UCs, I assume that's University of California system, are all getting together to create a data exchange. What do you think? Is it true? True, false? Who knows?
I haven't heard that, but I don't see them signing the data sharing agreement yet. So I think they actually receive a lot of public funds. So, say it
maybe
here.
They should do that.
It's public. So take a look. You both can look and see whether or not they've shared the data, if they've signed the data sharing agreement. So I guess that's progress if they're thinking about coming together and having some type of a utility amongst themselves, and hopefully they sign the data sharing agreement so that they can get their, my PCP for my daughter or my daughter's PCP can actually get the specialty information that PCP needs from the UC.
Yeah, by the way, my shade comment earlier was about a UC too. So unsurprisingly, very connected. Our friends here at UCSF could definitely get on this. That's very interesting. We love rumors, although as Timmy knows, this is all public records, so we should all take a look at it and see what's going on. I would really encourage the UCs to really consider, do they need to build their own HIE or their own data sharing network? They probably can also work with many other parties who have already done this in the state, public and private. Really encourage them to responsibly and reliably and efficiently use public funds, many of which have already been used to create this infrastructure in the state and the country. So TBD on that one, but that's my vote for them. There's actually another really good question, really quickly, just about because I did leave out, and I feel kind of bad. I'm sorry, Zach, friend of the show, friend of Civitas, Zach Finn, comments if there are any thoughts about Florida. Of course, Florida is also a massive state who has a ton of things going on, and I'm sorry that I just kind of diss Florida by leaving it out of my
and a few HIEs, just a few
HIEs too. So I would call it more of the slightly less organized. However, there is, of course, pretty strong work around Florida Medicaid and exchange.
I was going to say it's more business line centric.
But there are other parties. There are plenty of other parties. There are private HIEs like Centralis in the north of Florida. There's also lots of work done by Collective, now Point Click Care in general, both with the Medicaid, HIE, and others. So lots of stuff going on there, but also not super well coordinated at the state level. Probably because Governor DeSantis has been pretty busy in Iowa. I'm not sure if he has time for important health IT and HIE work. He might want to get back and focus on it, though. That's my advice to him.
Yeah.
Just a little political.
Well, listen, I'll say this, like if these universities are trying to get they're trying to make an HIE. I mean, the only thing is like public funds make you kind of like, you got to like listen to your mommy, which is the federal government. But like, listen, if a bunch of people want to make an HIE, make an HIE. Like, again, like God bless America. Like, let's make some stuff. But I agree. I also think there's things called laws and like mandates. And I believe the data exchange framework is you are mandated to sign that data sharing agreement. So like laws, I tend to not violate laws and mandates and stuff. So, there's that.
Can I give a plug for this idea of a chief patient officer?
Yes.
So California needs one too. So I'd love for you and states. And
states,
what is the role? What happened to that ombudsman role
Correct.
What happens when there's information blocking? What do I do? Where and how can I get that voice?
Yes.
So bring it on. And I'd love to be able to continue to kind of to map out what that job description looks like. And let's get it in
We're doing stuff. We're stuff like TBD. We're going to have a special guest here in a few weeks. Like they're going to tell us some stuff. It's going to be legit. But awesome. Timmy, thank you. Thank you for letting us roast on the data exchange framework. All right. On we go. So we've got another special guest. So this is Alex Koshkov. Am I saying your name right? Correctly?
Good enough.
Okay, well, all right.
Oh, Kat, that's a no.
I know. Listen, I can't say anyone's name right. I realize that I only see people's names on the internet, and then I'm like, oh shit, I'm gonna say the freaking name. Okay, so our friend Alex, he is COO of VKey. He's also COO of 2 startups. We met Alex because he watched our show. And then he sent us a delightful email because I think we may have been trash talking our great federal government for not funding Ukraine at the time. I can't remember exactly what we were doing, but we were probably trash talking. And as everybody on the show knows, Lisa and I are very pro Ukraine and raised a bunch of money and will continue to raise money. And Alex emailed us and said, "Hey, do you want a real Ukrainian for your show?" And we said yes.
And so the answer was yes.
Here he is.
Yes,
I had the great pleasure of meeting Alex in person this week in New York. He came to visit and interviewed me for his show. So that one was a little bit more legit than this one. I don't know, Lisa. There was like a real camera involved.
That's not us. We are less legit. Alex, tell us about yourself. Give us the rundown. Let's go.
Give us the dirty dirt.
Sure. Well, first of all, hello everyone. Lisa, happy birthday. I'm really excited to be here. And it's a privilege to be a first Ukrainian guest on your show. I'll try not to screw it up. I'm a co-founder of a software and hardware development company. Our main clients are digital health startups. US, of course, is the main market where we operate. And we do a lot of great products in this space. So I'm really excited to be in the US. And as a matter of fact, I realized that I have no idea how, even though I developed software for this market for 10 plus years, only when I got here to the US, I realized that I have no idea how the US healthcare system works. It's so fragmented and complicated. So I actually started a newsletter on LinkedIn. It's called the US Healthcare System Through the Eyes of Ukrainian Refugee. So probably for Americans, some of the ideas you find there might be too obvious and too simple. But for startup founders from anywhere outside of the US, I think it's important to understand how everything has worked, not only from a technological perspective, but from the business perspective.
Yeah, agree,
Yeah,
agree, strong
I
agree.
actually saw your. I read most of your posts, and they're really great. They're just about sort of the comparison between the Ukrainian and the U.S. healthcare systems. I'm trying to remember the way you phrased it. You kind of said like, "Looks great." This is my summary. Looks really fancy and nice, but is actually like terrible, ridiculous, inefficient service. Like looks incredible, like beautiful, clean,
Right.
fancy stuff, but like impossible to use. That's my summary. So you can tell me if I got that right.
I'm not gonna say that in those words, but you kind of get close to it, right? Yeah.
Yeah. So Alex, when we were talking earlier this week in New York, you were talking about like all the you work with a lot of different clients, a lot of different startups, right? Because your team, it sounds like, is helping a lot of early stage companies really get their ideas and their products off the ground. And you interviewed me, and you were like, "What are the biggest tips?" And I was like, "Well, what do you think the biggest tips are?" So in all of the startups that you talk to, like what are the recurring themes? Like, how do you know someone's going to be successful?
Oh wow. Few things and few tips, I guess. First, don't be prepared for the sprint. Be prepared for a marathon. The sales cycle is so slow in healthcare, specifically in the US. So if I've seen so many startups that just ran out of cash before they started generating revenues and close some contracts. So if you're not ready, there's really zero chance you're going to succeed at this market. So be prepared for this marathon. The second one would be kind of obvious, but from the technological perspective, please don't put security, don't make it an afterthought. Uh, Consider all the security
Smart.
standards from day one, because again, met and seen so many startups that think, oh yeah, when I start making millions, I'll think about security. But no, that's not how it works. And the last one, I guess, the last one would be I'll address all the startup founders in healthcare that are targeting the U.S. market outside of the U.S. What just I said in the beginning: do your homework. It's a good tip for any startup, but in healthcare in the U.S. specifically, do your homework. Learn who are your payers, who are your buyers, who are your users. You got to understand the market before you actually enter it. So don't think you're gonna develop a great product and then there you go. I'm famous and successful. Come to the US, talk to people here, see how everything works. I literally, before I got to ER, I didn't understand like what's the process here in the US and how it works. So all kind of those things and that experience helped you a lot to make a great product.
You have to use our broken healthcare system to understand how to fix it for sure. I think also what you just said is really interesting. We've ranted before on the show about the companies that are targeting B to B to C as their business model and how complicated and messy that is. It's almost, there was a period of time where it was almost hilarious to see people kind of going through that process of changing who they were selling to as they realized how difficult those models are and what you really have to understand about the market that you're targeting to do that. Like, I'm going to sell to
Yeah.
somebody who pays for healthcare for somebody else, but it's going to have to appeal to the end patient. And then also somehow the person who pays for it is going to have to also care enough to give me a lot of money for it. It's a really complex ecosystem.
100% agree. Yeah.
Yeah. I mean, that's wild too, because I mean, when y'all are building a product, it's not necessarily the go to market, right? Because we were talking about this too. There's a product, and then there's a go to market, right? So you might make a product that like theoretically works, but then is the incentive there to buy it? And I think that's so interesting. There's so many good ideas that like there's just no incentive to
No one's
buy,
going to pay
which
for
is
it.
like
No one's going to pay for it. Exactly.
totally freaking
Unfortunately, even
wild.
though they probably should.
Even though they probably should. So Alex, you were telling me about some like, so I think what's interesting is right, like US, like, we don't have any wars going on over here, right? But Alex was talking about some pretty interesting remote care technologies that they had deployed in Ukraine. That I think you said they're still operational. It was early days, and it's kind of like a care hub. I think you were describing. I'd love to just hear more about that and some of the other projects you have going on.
Oh yeah, sure. So this project you're talking about, we as a company, we are very proud of. So a little bit of a short story before that. So from the service business, we actually decided that we need to go to the product business as well. So we started developing some of our own products. And what we had in the beginning, a couple of years ago, the first product is a telehealth platform, really good one, lots of features. And right after Russia invaded, after the full invasion, just it took us, I don't know, a couple of weeks, and we rebranded our telehealth platform and launched a non-commercial project, basically a volunteer project. It's called Doctors for UA, and it's basically a marketplace where doctors from all over the world, but who knows Ukrainian or Russian, and patients, Ukrainians only, can get medical help because due to obvious reasons, a lot of people cannot get help nowadays. For some, their hospitals got bombed. Somebody became a refugee in a foreign country and they don't know the language the doctor is talking to. So we are very glad that so many people are involved in this now. So that platform is still up and running, and we have probably like around 7,000 patients, at least 400 doctors, probably like around 2,000 consultations, successful consultation for today. And yeah, we're paying for this out of pocket, but there are no regrets. We're happy it's helping people, and we're gonna continue doing that. And at some point, actually, we thought that we should go further, so we developed a medical device to help do the diagnostics for doctors during online visits.
Cool.
And not gonna tell you too many details, but I'm gonna launch a Kickstarter campaign in a month or two.
Nice.
And anyone who wants to support us, please do. We're gonna send those devices to the front line to help consult civilians who live close to the front line, because they just can't get any medical help offline. So yeah, very exciting. I'm really happy we're doing this. This is finally where business started and our knowledge started reaching some impact. So yeah, great stuff. I love it.
Lisa, I'm waiting for you to jump in and be excited, but you're probably waiting for me.
No, this is really, really cool. And Alex, it just sounds like you're involved in so much interesting stuff right now. I'm not surprised that you are extremely motivated to get all this work done and do things for yourself and also for your friends and family back in Ukraine and generally for the market, but pretty awesome. So big ups to someone actually doing a bunch of stuff, not sitting on his hands.
Stuff. Yeah, someone doing stuff. I mean, I think that's what's so cool. And I know we can't talk too much about that program, but because it's not launched yet. But listen, we got a lot of people here who love Ukraine and want to support you and your team and everybody still there and all the refugees. So when you are ready, we're gonna blow up the shit out of your GoFundMe.
We absolutely will.
Kickstarter campaign. And it's gonna be awesome. And that is really cool. Oh yeah.
Nice. Perfect.
Yeah, there we go. Yeah, because I know, again, I know our great federal government is kind of doing stuff, but I think the
not
phrase
so much
that
anymore.
I've been using lately is the U.S. is kind of standing around with our dicks in our hands and not getting us money where it needs to go. So, Alex, we are happy to support you anyway. We think you're awesome. That's so cool. And again, things that we don't think about in the U.S., like how do you get care to people on the front lines of a war? So that's awesome. And let us know how we can do stuff. We'll definitely blow the shit out of that on social media. And what else?
We also have just a comment here from a friend of the show, Ritesh Patel, again, about the experience of startups coming to the U.S. Because most startups coming to the U.S. from outside of the U.S. also underestimate the size of the market and the kind of capital they need for this market, which is kind of what you said as well, Alex. So definitely agree that it is a massive country. We spend a gazillion dollars on healthcare, and it's also super fragmented. So I think understanding the scale and scope of that and what you could actually feasibly attack or feasibly bite off from that entire market is definitely hard to conceptualize if you're not from here. So, your experience
to that point, please don't come to this market just to get some part of that gazillion dollars. You got to bring some value as well, not just to make a ton of money.
Yeah, we have a lot of people who are already trying to make a lot of money from healthcare. So that we are all set. We need people with new ideas, new solutions who want to help. Ideally, then later expand those tools and technologies to other parts of the world. So lots of good stuff, but definitely lots of people are already making a lot of money off of a very broken healthcare system.
Yeah, I will say that, don't come here, even if you're in the U.S., don't be like, I'm going to go make a lot of money off healthcare. It's got a big TAM, right?
Got a big TAM.
And I say this as a capitalist, like everybody knows, like red blooded capitalist over here. Like, don't come to healthcare and like just to make money off something that's busted. Like, please try to make a difference. Like, please.
True. Ideally, a positive difference, maybe not just any difference. A positive difference, improving healthcare, reducing the cost, stuff like that.
Yeah, agree. Well, Alex, any parting words? Because Lisa is dying to talk about the Chevron deference argument going on right
now. Please support Ukraine, stand with Ukraine as long as we need, and start doing some amazing and continue doing some amazing stuff in healthcare. We definitely need a lot of people who bring value in this industry.
Awesome. Well, thank you, Alex. Thank you for sharing all that with us, and share your stuff as soon as you can.
Exactly. We'll be sharing it to our entire audience. So excited to help. Thanks so much for coming on the show.
I appreciate that. Yeah. Thank you. Bye-bye.
Awesome.
Oh, I freaking love that guy. All right. Okay, Lisa, the moment you've been waiting for.
Okay.
This morning, Lisa, she almost died, you guys. She sent one of our legal show friends and me this. She was like, Chevron deference is on the daily this morning. What's the New York Times podcast? And like, listen, I didn't really have a lot of time to listen to it, so I had to Google it. So Lisa, tell us why this is such a big freaking deal.
Do you know what the Administrative Procedure Act is? Of course you do. It is basically how all the federal agencies do all of their regulations. And so you have laws from Congress, and then you have the regulatory state, which is the executive branch and all of the parts of the administration, HHS, the VA, the EPA, all of the various different parts of the federal government.
You kind of start dancing when you talk about laws and rules.
Listen, APA is very important. It's also very, very nerdy. And there's this entire regulatory state that is built up around the APA and all the various interpretations of it. And violating the APA is a big deal as well. Okay, long story short, I am not a historian of the Chevron doctrine, but essentially about 40 years ago, they said, hey, when a law is a little bit vague about something, a judge should rule on the side of the administration of the agency who is writing the regulation to interpret the law. And that means that, like, if somebody says, like, I don't know, like, that seems like a pretty weird interpretation of a law, they're basically going to say, you know what, default to what the administration, what the executive branch says. And now the very conservative Supreme Court is taking this up as a big project this term to potentially overturn the Chevron doctrine, which says then basically they're not going to by default go with whatever the executive branch, whatever the administration says. And that's a big deal because there are so many laws that are pretty vague. You may know that Congress is not amazing at passing new laws. Slight weakness of our friends in Congress could pass some more laws, but they also leave stuff kind of vague so that every successive administration can do a new interpretation. And just going back to our world of health tech and health data, think about artificial intelligence laws in the futures. Think about the 21st Century Cures Act and things around information blocking and around TEFCA, for example. Lots of things would be potentially up for some real challenge in the future.
That's a gray area.
Lots of gray areas there. And I just noted that Mickey Tripathi, Director Tripathi of ONC, just noted that the next health IT regulation is in OMB's inbox right now, HTI 2.
Oh, shit.
So I don't know, guys. A little iffy.
You know, well, here, I'll say this. So everybody knows I'm a little right of center. Lisa's a little left of center. But in the general centrist realm, we are both centrists. Kind of strange.
We are.
But like we normally don't totally agree on all the things. But this morning you said conservative justices, however, strong argument. And I was like, whoa, that's the first time I've ever heard her say that.
Listen, this is not super straightforward. Like, should Congress do a better job passing laws that say what they want to have done? They are that's the branch of government that's in charge of passing laws. I would say yes, they should pass more specific laws. But also, I love regulation, so TBD on that one also. All of my friends and all of our collective friends who work on health IT regulation, health data regulation, health privacy regulation, I mean, this is a space that is going to change pretty quickly overnight if this is actually overturned and something real happens here. So this has pretty significant this could have a very significant impact on the way government works. And by the way, this is for every administration. The Trump administration used regulatory oversight and the ability to sort of reanalyze what a law said to write new regulations, as did the Biden administration, as the Obama administration, the Bush administration. They all did do this. So it's not just liberals or conservatives. This is a massive, massive change of how government can work in the US, in my opinion.
I think you are more excited than when we were talking about
I
unions.
do. Listen. I love the APA. Oh my gosh, you guys, it's amazing.
It is amazing. So give us an example of like with information blocking, because that's a little bit more nebulous and ambiguity.
Yeah. I have a great example. Great. So information, and it's probably someone who's an actual expert. Like, this is not right, Lisa. You are wrong. Fine, whatever. Don't at me.
I'm ready.
You can say, essentially, the law defined information blocking. 21st Century Cures defined information blocking, and it gave a lot of leverage to ONC and to HHS to generally to sort of further define that and further clarify the exceptions to information blocking. It's possible they could say, hey, we don't agree with that interpretation. Those exceptions they don't hold up to scrutiny. So they would say, well, those exceptions are not enforceable. You cannot, if someone's information blocking, screw your exceptions. Or they could say, oh, that exception you added about TEFCA, that's completely null and void. That makes no sense. So things like that could potentially change. I don't know if that's going to happen. I don't know if there are any other interested parties who are really concerned about TEFCA and information blocking, but maybe they are. Maybe they'll bring a court case. Who knows?
I mean, it sounds like ambiguity, which I am a fan of. Like, I'm ready.
Right. It's a lot of ambiguity. And by the way, like how does this stuff actually change? It changes through court cases, through legal action. And as you know, you get a couple of attorneys involved, and you're looking at 10 years of ambiguity, which is perfect for someone like you, Kat, to go in and say, we're going to solve this.
Love it. Well, we have a lawyer. We have a lawyer coming on our show soon. When's Alia coming on our show? It's not. It's next
soon,
time.
I think.
Next time. We have a good lineup next week. We have Rochelle Prosser and Kevin O'Leary. OMG. But then I think the next show we have Margaret from Flare Capital and Alia from MWE to actually tell us about like laws and stuff. So that's going to be really exciting.
Amazing.
Then so that's great. Look, Lisa, looking forward to all of the drama here.
Let's see what a real attorney has to say about the APA, because Alia is definitely smarter than me, and she's actually a real, very accomplished attorney. So we'll see what she has to say about it.
Yeah, I agree. We should wait for her. She is like our favorite lawyer, FYI.
She really is.
Yeah, we're very excited. So we got 3 more minutes. Let's talk about Brendan Keeler, friend of the show, often wrong, never in doubt, in the same category as me. That is not an insult. He had some interesting posts the past couple of days about like data hunters and people like not understanding TPO. What do you think?
Right.
Yeah, it was pretty dramatic.
I do think that he is often wrong, never in doubt. But in this case, he might have something to say about it. Why don't you tell us what you think? Dumpster fire.
Obviously, I loved it. Obviously, oh, hold on.
We've got a dumpster fire coming up.
The dumpster fire image is here, but we're not on it, so I got to switch us back. So, no, I loved his post about kind of some what can go wrong. And then I loved his post too. And then the mayor of New York, Health Tech, Raihan, showed up and also agreed with Brendan's notes on some of this stuff. So yeah, it seems like a lot of these health data organizations aren't necessarily super legit, right? And that's a problem. I had a discussion about this week in New York as well. Is that what is treatment? What is treatment really? And it goes back to kind of what you're saying, right? Like, there's a lot of gray area. Like, why should the gray area be there, and who's interpreting it, and who's fighting for it, and what process do we have to get things cleared up? And I won't go too much.
Well, I mean, my opinion here, which is that I think this is often it's very sloppily used. It's often used in a way that is not totally legitimate, not totally ethical. That means using treatment purpose to gather data for other purposes, which is not allowed. But again, you have to be able to show. Yeah, and then sell it. You need to actually be able to show that, right? There has to be enough people and entities out there, searching for that type of illegal use to actually find it and actually make sure it gets addressed. There isn't like some massive enforcement arm of the government who's able to do this. They don't have enough time. There's like 12 of them. how are they going to do all this work? So it's a bummer because it's happening so frequently and it's so hard to actually catch and stop.
Yeah, but I will say, shout out again to Timmy and the work her team at Connecting for Better Health is doing.
That's right.
Is it like work groups like that, coalitions like that, people who are paying attention and engaged in building things like I think that's how we get everybody on the right track here. Because there is risk. There's a lot of risk. And as Brendan's post noted, if there aren't like clear pathways and clear bridges to get that data, people will dig tunnels. They'll march through the mud. They'll build shitty bridges, right? All kinds of things happen. So while I am a skeptic of all mandates in general,
Totally.
I actually think that the data exchange framework will teach us some things. Kevin, I hope you shout me out in the comments for being a believer.
I know. I mean, listen. The best thing you're going to do is get enough of the interested parties together in the way that Connecting for Better Health are doing, the way that others are doing as well, because it's so hard to do just like hard enforcement. That doesn't really work in the space. You can try, you can have fines. The fines then become part of doing business, the cost of doing business, right? We've seen this before again and again and again. So again, the best thing you can do is get people together and say, let's do this together for the good of California or for the good of America, Kat. And that's the best way to get them all to move forward.
Or like, I don't know, like Missouri. Well, probably not Missouri. But anyway. All right. Okay. Show's over. Right. This was great. Thank you to our wonderful guests. Thank you to our loyal followers. Thank you, Lisa.
Illustrious guests, illustrious followers. Thanks, everyone.
Da, da, da.